So first of all, I would really like to thank you for being here today. It's really my pleasure. And for those of you who came from Belgium, from France, I would just like to say merci beaucoup d'être là. Ça me touche vraiment beaucoup. So the title of the lecture is how can we be more efficient? So I will first give you the plan of this lecture. As I am a physician, I have to start from the beginning, and the beginning is the patient. So I'm going to tell you the story of a patient. And the end, it's also a patient. So I'm going also to tell you the story of a patient. Then we need something, right, between these two patients. I'll first disclose my long list of failures, my track record of problems, issues, and failures. And then we could try to think together how we could do better, how we could accelerate clinical development in children. And finally, we could dream together about not to treat the disease, not to cure the diseases, but to make it disappear. And then we could continue this lecture with a glass of wine. So this is a gift for someone in the audience. Andrea, you will recognize our good friend, common friend, Youssef. So Youssef was one of my first patients when I was a baby myologist 15 years ago. And here is he in Paris. He has a Duchenne muscular dystrophy, doing one of the most stupid tests ever, which is the 10-meter walking test. So we asked the patient to walk as fast as possible during 10 minutes. We have even more stupid test, which is to walk 6 minutes straight as fast as possible. And that day, the mom told me, well, he's not doing perfectly well. He is not as strong as usual. And I say, oh, what's happening? And she told me, yeah, because yesterday we went to visit the Eiffel Tower and he's tired. So we were gambling decades of research, millions of investment on the basis of a child walking 6 minutes in a corridors and tired because he visited the Eiffel Tower. What kind of solution can we propose? Well, for instance, to count the clinical trials in cities where you don't have the Eiffel Tower, but places that are more, less tiring for children, like Brussels. And outside the pleasure to bring mannequin piece in Oxford, I just also wanted to introduce a famous Belgian citizen from Belgium that will help me through this lecture, René Magritte. But I will propose you some of this thought later. So the trials in which Youssef was included was not a failure, was not a success, because actually we don't know if it was a failure or a success. Can you imagine? I mean, running a trials and even not knowing if it's a failure or a success. And while the drugs did not go on the market, so we could think it's not a success, but actually we even don't know why. And we had a track record of drugs that not only did not reach the market, but we even don't know if it's because the drug was not working or if it's because we were unable to demonstrate that it was working or not, which is the worst case scenario, of course. So I had so many failures that with my PhD student, Dora, we decided to write a list, right? And to write a paper about all these failures. This is the list. This is the list, the list of trials. I mean, 15 years of failures. That's huge. And that's the one I was part in. So behind all these trials, there are patients, there are doctors, there are expectations, there are clinical research associates, there are teams working hard to make these trials happen. And sometimes we even don't know if it works or not. Why? How could we do better? Well, let me introduce the vision of René Magritte with a Belgian painter. And this is a painting that is called The Lovers, 1928. And I will call it a double-blind randomized placebo-controlled study. And this is actually one of the problems that we're facing is that when we conduct a double-blind randomized placebo-controlled study, we consider a large group of patients, and we split this group of patients randomly between patients who receive the treatment and patients who receive the placebo. right? And we don't know which patients is on placebo. We don't know which patients is on treatment. So then we compare the evolution of patients A and the evolution of patients B. So we don't compare actually patients A with himself. We compare the evolution of patient A with the evolution of another patient, right? It's actually like if we were comparing apple and oranges, okay? So how could we do better? Well, let's imagine a theoretical trial, right? A double-blind placebo-controlled study to assess the efficacy of a single IV dose of calcitonin. And let's imagine two patients. Let's call them John and Jack, right? Those two patients are surrogates of a group of patients. So, but let's consider individual patients, but we could consider that they are a group of patients, right? John is very happy. He doesn't know why. It's because he's on treatment. Jack is not cantankerous, is on placebo, but he doesn't know it. He doesn't know it actually because we have the blind. So that's the baseline, and that's the final assessment, and that's what happened. And you could say, okay, this is a negative trial, right? The evolution of John and the evolution of Jack is pretty the same. Even John declines faster. It's a negative trial, and calcitonin doesn't work. Okay. Let's take our superpower. Let's go back in the past, and let's try to be more clever. And being more clever could be, let's try what actually happened some years before the trials. And let's try to figure out what is the trajectory of John and Jack. Well, actually, if we had done so, we could have seen that this was the trajectory of John, and this was the trajectory of Jack. We could have constructed a model of the evolution of the disease and apply this model to the individual cases, John, Jack, or any patients in the trial. That's what we call Bayesian statistics. And we could have projected the evolution of John with a confidence interval, because we can predict the future, but to a certain extent, there is an uncertainty, and the evolution of Jack. And what we can see is that actually John is above the projection of where we were supposed he will be 1 year later. And Jack is exactly where we projected this evolution. So actually, this little man is a responder, is better than what we could have believed if he had not drug. And John, who is on placebo, is exactly where he was supposed to be. So calcitonin then becomes an efficient drug, and this becomes a positive trial. So you could tell me, well, this is not, super brilliant. Bayesian statistics have been described 300 years ago by John Bias in Edinburgh. Say, okay, fine. But the application of Bayesian statistics is quite recent in the field of rare disease. We wrote this paper in 2021, and there's a very interesting paper that just came out 2 days ago in PLOS ONE about Bayesian statistics for Becker muscular dystrophy. How could we use this concept of projecting the future of patients and comparing the patients not with another patient, but what we anticipated would be the future of this patient. So patients are not compared to other patients. They are compared to their own projection, right? And this is, from a philosophical perspective, completely different, because me as a patient, I don't want to be stronger than my neighbor. I don't care. I want to be stronger than at the beginning of the trial. I don't care of being actually a better responder than another participant in the trial. But also we can reduce the number of patients, and we can reflect the actual objective of the patients, which is to be responder to the drugs that they are exposed to. But of course, to construct such model, you need a lot of points, right? And the more points you have, the more precise you are. So it's an investment. You need to work beforehand. You need to collect the data beforehand. It's a kind of investment to reduce the size of the trials. So you need to be clever, to think beforehand, to get the right outcome, and to have the quality of data. So Bayesian statistics, and that's the first solution we can propose based on natural history, allow to dramatically decrease the number of patients in a trial. But that's not the only problem. We have a second one. You remember this one? Eiffel Tower, right? When we assess patients in the clinic, we assess them on a very single day. that day, if the patient is not in a good condition, because he's tired, because he went to the Eiffel Tower, to the mannequin pits, to wherever, he will be tired. And the problem in rare disease is that these patients are coming from everywhere in the country because it's a rare disease, and they go in a major center, which is in a big city, where there's a lot of things to see. So these patients are tired when they come. They have traveled. So even Bayesian statistics cannot assess this point, right? So if we could start dreaming about not having a point assessment, but having a continuous assessment and using the reliable technologies, we could, for instance, imagine, do you remember the evolution of John and Jack? This is the evolution of a treated patients and untreated patients. Obviously, the curves are separating progressively. But according to when you consider your final endpoint, you can reach the conclusions that there is no difference. But if rather than to consider a single point, you assess actually the area under the curve, then you are much more powerful and you are able to capture a difference that you're not able to capture by just taking a point assessment. So that's the concept of continuous monitoring of the movement. So you could say, okay, fair enough, but we are in 2022, wearable devices are in our life with the Fitbit, the Apple Watch. So why don't we use this technology today as primary outcome in our clinical trials? Well, for a very simple reason that I call the syndrome of the Christmas gift. I am a clinical trialist and I received from my mom an Apple Watch or Fitbit for my Christmas. I'm so happy. And then the day after I go running and say, wow, I've exercised more than the day before. And you know, it helps me to keep being fit. Fantastic. And then on Monday morning, I say, well, actually, I conduct clinical trials. I could use it as an outcome for clinical trials. What can I do with that? And the short answer is nothing. Nothing, because it's not done for that purpose. It's done to be a nice Christmas gift, to monitor your activity, to encourage you to have a better activity, but it is not a medical device. It is not to be used to measure something in a patient. And with the change of temperature in patients who are going out, who are going in, after some days of recording, the precision decrease and you are into the white. So we start working more than 10 years ago with the engineers of a team, SysNav, from which Melanie was here today, works today. And it was kind of a continuous dialogue with them. The engineers were super cute. They told us, I will offer you the moon. And we say, well, thank you, but I prefer alter of movement, right? Being able to measure continuously the movement. What do you mean exactly? Well, being able to identify all the movement of patients and to quantify them precisely in an uncontrolled environment during 2 years without shift over the time period, internet transmission, data security, be compliant. And you say, well, are you sure the moon is not enough? And it was a lot of work. It was a lot of work. And it was a long and winding road that started in 2010 with a device that was, full of sensors, not wireless, impossible to do somewhere else than in the lab. But we could identify the right sensors. We could identify the right way to calibrate these sensors, and we could move to this terrible device in 2011, and then to this one, which was not so terrible, but quite terrible also. But we could start acquiring data in patients, and finally, in 2017, it was qualified as a medical device, and we could get the approval of the European Medical Agency as a secondary outcome in Duchenne muscular dystrophy, and today we are applying to be a primary outcome in Duchenne muscular dystrophy and at the EMA, and for other disease at the FDA. We will talk about it later. So that's how it looks. That was the previous version, the new version, and the weight of this kind of technology. And as you can see here on one of our top model in Liège, it's pretty easy to integrate in the daily life. So how does it work? The first thing first is to be sure that what you measure with this kind of device is actually what the patient does. So we first compare with a a mock-up, so a motion capture, and we could find a perfect correspondence. And then we tried in patients, and that was two ways to measure the 6 minute walking test. You remember this stupid test where we asked the patients to walk during 6 minutes in a corridor. And we tried to measure this test using this kind of device and using a physiotherapist like Charlotte. And we had a pretty good correlation, but not that good, because look, the device was overestimating the distance on a systematic way. And we could not find why. I was desperate. Really desperate. And then we finally understood that it was very simple. Actually, when we conduct this test, which is 25 meters, the physiotherapist will say 25, 25, 25, but the patient actually, he has to turn around, right? So it doesn't walk 25 meters, he walks a little bit more each time. And we can even calculate how much, and we can correct. And then if we correct, the correspondence is perfect, which means that actually we are more precise than even a physiotherapist. So then you could say, that's fantastic, great, but the variability is huge, right? And I have two theorems from my career. The first one from Paris, theorem of Servais. When the French are on strike, they walk more, of course, because there is no public transport. And the Servais theorem from Oxford, when it pours, British people walk less. When it simply rains, they walk more, right? So our pattern of activity outdoors depends on the weather, depends on many factors, right? So how can we apply it in a clinical trials? Because it changes all the time. Well, true. Let's imagine that this is the life of a patient. He lives with his mother, and she's a sport woman, very active. Then during the weekend, he goes to the cousins, the mother's side. They go in the countryside, they run, they have fun. Parents are divorced, then they go to the father, a little bit less active, and the cousins, the father's side, even less active. So huge variability. And if you measure the variability on a day-to-day basis, it's huge. But if you average on a 3 days period, then it decreases. If you average on a 7 day, 9 days period, it decreases. So which means that your variability is simply a function of the duration of the recording. So you can play with your variability. You can accept the variability. And it depends also of the evolution of the disease. If the disease is evolving every day, then you need a very short recording period. If your disease is pretty stable, you can record for 6 months, right? So we could finally understand that in Duchenne muscular dystrophy, for instance, the optimal duration of recording is 180 hours. And according to this duration, we could try to figure out what is actually the best centile of stride velocity to study in order to get the best response in treatment. And I will show you the results we could obtain with the 95th centile stride velocity. 95th centile stride velocity is actually the 5% most rapid stride that you normally do in your current life. It is absolutely independent of the compliance. It is independent of the weather. It depends only on one thing, the weekend and the weekdays. And my teenagers were actually subjects in the study can testify that during the weekend, they walk much less than during the week. So we have a lot of normative data, and we could actually identify what is the minimally clinically important difference, and to follow a cohort of patients with Duchenne. And as you can see, there is a clear decline over time, and that we can capture a decline over a 3-month period that is confirmed after 6 months, 9 months, and 12 months. If you use the classic 6-minute walking test or the North Star, you need 9 months to capture a change that you can capture in 3 months. And if you start treating your patients with steroids, immediately you see these patients doing better. What does it mean? It means that it's quite easy to estimate how many patients you need to conduct a trial. You have mathematical formula. Not going too much in the detail, this depends of the change over a 1 year period, over a period of time, and the standard deviation of this change. If we use the 6-minute walking test, we need 112 patients per group, which means that if I want to demonstrate that the drug works or not, I need 224 patients. That's why the trial in which Youssef was included had no chance to be successful. If I use this kind of technology, I can use 14 patients during 6 months. So this kind of technology has the potential to dramatically reduce the number of patients that you need to conduct the trials and the duration of a trial, which means that you can accelerate clinical development by using much less patients. You can cut the cost, you can cut the number of patients, and you can evaluate many more drugs during a shorter period of time. So this was the first digital outcome approved by a regulatory agency. It was the European Medical Agency that qualified this as a secondary endpoint in Duchenne. Now they are fully considering as a primary endpoint. And they were so surprised themselves that they published our own results without citing any of us in the authors, which is the first time in my life it happened, but we were so proud that the regulators from the EMA were publishing our own data. This has been achieved thanks to the support of an entire community. And then we could start dreaming about using this kind of technology in many other diseases, like, for instance, spinal muscular atrophy. And Melanie was in the room today, demonstrated that in spinal muscular atrophy with type 2 or type 3, we can capture a change within 6 months. We don't need 3 years. We can do it in 6 months. We did it also in facioscapulohumeral dystrophy, and we demonstrated that within 4 months, we can demonstrate a change. But then you can say, okay, this is neuromuscular disorders, right? You like neuromuscular disorders, but can you use it in other conditions? Well, what about Angelman syndrome? Angelman syndrome is a very severe condition in which patients present with ataxia, seizures, and intellectual disability. How can we measure something in a child who will refuse to do anything that you ask him to do? No possibility to test these children. Well, if you just passively record their movement, you can measure the gait of these children.
Hi, my
and you
girl.
can see how the strides are stereotyped. They actually, every single stride is the same. There is very few
Good
variability,
ball.
which
Hands
is
down,
not
stand up.
efficient. Because if you're
You're
not
okay.
able to slow
Yep.
down,
You
if
can
you're
do
not able to
half heel. Stand up.
accelerate,
Up, up, up.
then you have an accident if you're driving.
Good girl. Up,
And
up,
this
up.
accident is
Up,
for the fall in a
up,
patient.
up, up. Good. Hands down, stand
Actually,
up.
we could demonstrate that there is a drop in the variability in these patients, and we are exploring several outcomes. There is a letter of intent that has been filled to the Food and Drug Administration. And then we went to other diseases that are much more frequent, like Parkinson. And we are trying to capture every single aspect of Parkinson disease, not as an activity monitor, but as an alter of movement, to be able to capture the full spectrum of the symptoms of Parkinson, including dystonia, including tremor, including freezing. And we can push the envelope and to go to even more frequent disease like multiple sclerosis, which is fascinating because you may have so many symptoms in multiple sclerosis that you can actually capture with this kind of technology. To evaluate patients with wearable technologies rather than with 6-minute walking test or skills is just a sense of history. That's just what's going to happen. And the regulators know that. So for instance, the FDA has funded a digital health center of excellence, and the number of digital endpoints that are used across the different clinical trials is just exploding. Now we are, that was 6 months ago, there were 166 digital endpoints used rather than 34 6 months before. So this is another possible solutions, not only to use Bayesian statistics to allow to compare the patients with themselves, with their own evolution rather than with another patient, but also to use this kind of technology to allow objective and continuous evaluation that allow to decrease the number of patients and the duration of the trials. And in the bonus, what we're learning in the field of rare disease can be used in the context of more frequent diseases like Parkinson or multiple sclerosis. And then comes a third problem described by Magritte in the Human Condition, 1933, and I will call this the window of opportunity. What does it mean? Well, let me tell you the story of spinal muscular atrophy. I talk about Duchenne muscular dystrophy, which is a disease of the muscle, but another of my dear little disease is spinal muscular atrophy. Spinal muscular atrophy is a disease of this cell, motor neurons, that gives the order to the muscle cell. And because of mutation, it's rare mutations. Well, actually, it's not that rare. It affects 1% out of 50. Probably one of us is a carrier. It's not a problem. The good news is it's not a problem. You can be a carrier, no problem. The problem is if you meet another carrier and have children, then you have 1 chance out of 4 to be affected, right? So it's not that rare. It's rare, but not that rare. And if unfortunately 2 carriers have together a child, and this child has the deletion of exon 7 of SMN1, then this child will get spinal muscular atrophy and the motor neurons will die. They will never resuscitate. It's no way. And the muscle, it receives no order. It's gone. It's like a PhD student without a supervisor. It doesn't do anything, and it gets atrophied, right? We have a broad spectrum of spinal muscular atrophy, but the most frequent and unfortunately the most severe form is that one. Is this kind of baby. Look, she's looking at you. She's intellectually normal. She's entering easily in contact with you. She has already paradoxal breathing, difficulties in breathing. She needs a G tube to be fed. She has no tones, only small movement. And unfortunately, in absence of movement, this child will die within a couple of weeks. So this is a terrible disease. And again, we had a long track record of failures trying to find the drug that works in this disease. We tried riluzole, it doesn't work. HGH, it doesn't work. TRH, it doesn't work. Gabapentin does not work, and creatine does not work. Then we tried valproic acid. Bad news, it doesn't work. Then we tried to add valproic acid and levocarnine, it doesn't work. Phenylbutyrate doesn't work. Salbutamol, some people say it works, but unfortunately it doesn't work. And hydroxyurea doesn't work. Again, long track record of failures, and behind all of these failures, there are patients, there are doctors, there's a community which is highly supportive of this development. But we got a new generation of drugs that interferes with the splicing of another gene, SMN2, that really looks like SMN1, and that allows the production of a full SMN protein, either using an antisense oligonucleotide, either a small molecule that interferes with spliceosome. We could even do something that we were dreaming about for years, for decades, is to bring a new gene using AAV vectors, bringing a new genes under the control of a promoter. And now we are even thinking about muscle regenerations. Well, this gave rise to an incredible number of clinical trials and fantastic track record of success of these different drugs, with plenty of high-flying papers, and finally 3 drugs that were approved and that now are currently on the market and that are used in the context of spinal muscular atrophy. So today in spinal muscular atrophy, we have 3 drugs that we use here in the UK. Nusinersen, which is an oligonucleotide that you inject intrathecally, Avexis 101, which is Zolgensma, the gene therapy, one-shot therapy, and the risdiplam, which is an oral compound that you take every day. So those 3 drugs are approved and on the market. And we have new drugs that we're currently developing, acting on the muscle itself. I don't want to show you the results with graphs, with histogram. We don't care. Let's just have a look at what it means from a patient's perspective. This is a patient with spinal muscular atrophy, very typical form. You don't need to have upside down. But as you can see, is hypotonia. Nice guy, just looking at you, smiling, trying to interact. He was included in one of the first trial, double-blind, randomized, placebo-controlled. Can you imagine, in such a severe disease, to run a double-blind, placebo-controlled study? And if you have such a condition, normally you die in a couple of weeks or so. But this child did not die. He was actually able to progress, and I hope, yeah. And he started acquiring new skills, like being able to pick up his little toy, to turn around, which is completely unexpected in this condition. So this child was really progressing, and he was obviously not on placebo, he was on drug. And that's the same child 1 year later is doing something I'm unable to do, is to work without looking at the computer, sit on the desk with your hands behind your back, try to do it. You will not be successful. He does it. It's completely useless, but he does it. And he still progresses. And that's the same child a little bit later who is now able to try to make some steps. This is fantastic. This is a child normally who should be dead for months. He's alive, he progresses, but he remains with a very significant disability. And he will probably never walk alone. He's on non-invasive ventilation at night. It's much better than being dead, of course, but he will probably not progress until full ambulation. And the reason is that he has lost so many motor neurons. There is no way to bring new motor neurons. We have just stabilized the disease. We have stopped the progression of the disease. Now we just hope for the growth, for the development of this child, but we will not go one step further, probably. And one of the last papers that was published in all the patients. It was published just some weeks ago in Lancet Neurology, and we tested 180 patients. 120 were on risdiplam, 60 were on placebo. And look, these patients were 9 years old. 9 years old as an average, but some of them were 25 years old. So broad range of patients. Actually, the age of Youssef, the age of Duchenne patients that we are assessing in the trials. Well, we finally could catch statistical significance by the skin of the teeth. And it's only after 1 year that we could see a difference between the placebo and the treated patients, which means that a drug that works obviously. You don't even need a trial, you just need a camera. When you go in all the patients, you need a lot of patients, 180, and you could miss the demonstrations just because you are beyond the window of opportunity. So we went one step too far by going to patients who are older. Could we go one step before? The short answer is we could. And I started dreaming one day when I met this family. Those two kids have spinal muscular atrophy. But this young man was affected, and the mother came to us and she asked for treatment, and she was pregnant, nearly delivering this little terror. And actually, we could treat those two kids who have the same disease. One, after the symptoms, is doing better, he survived, is able now to sit normally, but she is completely normal. She has been treated before the symptoms. He has been treated after the symptoms. She has been treated at birth because she was lucky enough to have a brother that is affected, and we could treat this child earlier on. Then you can say, okay, but she will develop the disease. Well, okay, let's continue to observe this little terror and to see what happened to her. Oops, sorry. That's what she does when she wants to look at herself in the mirror. So she's definitely normal. This is a new test that we call the big yellow plastic duck test. We don't know how to demonstrate how normal she is. And later on, we imagine new tests like carrying your baby during a 10 stairs test. She does it properly. It's too easy for her. So then you carry your bike. That's a child treated before the symptoms. Then we took the opportunity of this window of opportunity to treat this child, right? And that's the last video I have of this family. So that's the same kids. Now she's 4 years old. She's still completely normal. The brother is alive, but obviously not ambulant. These two kids have the same disease. They are brother and sisters. They have the same disease and the same treatment. The difference is a couple of weeks on when we deliver the treatment. The difference is related to the window of opportunity. You could tell me, okay, that's one case, that's one family. No, it's not one case, not one family. This is another family in which I could start the treatment in the two kids together, the baby and the sibling. As you can see, the sibling is wheelchair bound and will remain wheelchair bound forever. But this one, when she has to climb the stairs, will do it, as you will see in a couple of seconds, extremely easily. So these are observations, individual observations, quite convincing. You don't need thousands of patients. You just have to look at them when they climb the stairs. This is not a child wheelchair bound, right? But we have also studies. And these studies was conducted in 25 children. And the good news is those with 3 copies of SMN2 have a complete normal development. Those with 2 copies, some of them have a mild delay. When you have such patients under your care, you dream every night about newborn screening. You think every day about newborn screening. You think about a society where we can detect the rare diseases at birth, and when we have a treatment that works, to be able to deliver it as soon as possible to enjoy this window of opportunity. And so 4 years ago in southern Belgium, we could start our project Sun May Arise with our 3 partners in crimes. Tamara was in the room, François, Jean-Hubert. We screened altogether 180,000 newborn. Every single newborn southern Belgium were tested for this disease. 15 of them were identified and could be detected and treated at birth and are doing perfectly well, which means that technically this disease is disappearing progressively of southern Belgium. Well, we made a lot of public engagement, as you may imagine. It's probably the most secure testing ever. This is the difference between patients who are affected with using a qPCR, and these are the patients who are heterozygous or homozygous. As you can see, we have a very, very safe margin. We have no false positive. We have no false negative. It is probably the only screening ever that is so secure. This is the first child in Europe who has been injected with gene therapy at birth. And that's a consultation I had with him some weeks ago. He's not dead, certainly not. He's doing perfectly well. And that's a nice consultation when it's the patients who takes care of the doctor and not the doctors who takes care of the patients. Look, it takes my reflexes, and I've got reflexes. I don't have spinal muscular atrophy. I'm so happy. This is very easy consultations when your patients are doing that well. So then you could say, okay, that's fine. Nice idea. But how much does it cost? I mean, you want to screen all babies at birth. What's the cost of this? Well, okay, it costs a little bit of money. Altogether now in southern Belgium, it costs €5. €5 per baby. And we need to detect 10,000 baby to screen 10,000 baby to get one. So we need to spend €50,000 to catch a baby, right? But this baby will be treated before symptoms. He will have a normal future. He will not need a wheelchair. He will not need a non-invasive ventilation. And that costs a lot of money. So I've got someone in the room today, and she likes money. She loves money. And she counts every single cent that costs these patients. That's her PhD. So I tried to make a kind of extrapolation for you. We have 735,000 newborns per year in the UK. It means that we have about 72 newborns per year with spinal muscular atrophy. 5 years ago, when we had no treatment, 44 of them had the most severe form and died. 23 of them had a type 2 or type 3 and were wheelchair bound, and 5 of them keep being ambulant. That was the situation 5 years ago. This is over. Now we have a treatment. So that's the situation today. The situation today, we have 72 kids who are born. Unfortunately, we arrived too late for 19 of them. And I can tell you that lockdown was terrible for patients with spinal muscular atrophy because diagnoses were delayed in these patients. So 19 of them will be treated too late and will die. 38 will remain wheelchair bound, and 15 will keep being ambulant. That's the situations today in the UK. But if we could screen, as we do in southern Belgium, only 2 will die. The most severe form, the one that starts during pregnancy, and the patient is in such terrible condition that it's better not to treat. 7 will not be detected because there's rare mutations that you cannot detect by newborn screening. They will be wheelchair bound, but the other will be ambulant. And that's the difference actually between these 3 scenarios. And then if you start counting the number of wheelchair, you could say the problem is that after 20 years, if we treat these patients and we do not screen, we will build kind of snowball of patients in the wheelchair. We need non-invasive ventilation, who cost a lot of money for the NHS. That brings a lot of burden on the system. And this is going only to grow and to grow every year. That's the situation in 20 years in the UK. So Tamara, who is this lady who counts so much the money, who likes so much knowing how much cost a patient, will publish in the coming hours or day this paper that actually compute the cost of patients who are treated after, because they are identified by the symptoms, as we do in the UK, patients who are identified by newborn screening, and of course, patients who are not treated. I extrapolated for you the data from this paper, and I can tell you that the cost to implement in the UK could be 2,500,000 euro per year. Sorry, it's in euro. The total cost saved per year would be 143 millions of euros. So you invest 2 millions, you get 143 millions, which is no brainer. It's a financial return of 5,739%. I mean, it's better than Bitcoins, right? Better, it's better than Amazon shares, whatever you want. Try to indicate me a better investment. And then you can start making some calculation. And I can tell you that each minute that we do not screen in this lovely country cost us as taxpayer 240 pounds. So the cost of this lecture is actually 15,000 pounds, because during 60 minutes, I'm talking and we're not screening for spinal muscular atrophy. Each minute that we spend not screening is 240 pounds. This is too much. And we know that in several countries, the newborn screening is expanding. We made some estimation on how many newborns per year will be screened in the different countries, and there are plenty of pilots everywhere in the world that are starting or that are completed for newborn screening. The good news is that now we are screening in the Thames Valley in Oxford. We have a screening that is active thanks to the hard work of Corinne, of Christine from my team, who could raise it up. And now we want to expand it, and we want together to bring the case to the newborn screening committee. I can tell you it's not easy. I can tell you that in my life, I've met conservative people, very conservative people, extremely conservative people. And then I met the National Screening Committee. That's really the next level. But we have to do it. I mean, it's no brainer, of course. And that's maybe the third solution. Newborn screening allows to evaluate the efficacy of drugs that have demonstrated their safety and target engagement in a population in which the potential effect is much higher. In these 15 kids identified in newborns in southern Belgium, 6 of them were included in clinical trials. So which means that not only newborn screening was a nice opportunity to demonstrate the efficacy of drugs, but also not only we saved patients, we helped patients to have a normal life, but we could use these patients to demonstrate the best efficacy of the treatment. So it's a win-win-win-win-win solution. I promised to finish this lecture with another story of patient. This is a crazy story. This boy is born in Lubumbashi. It's in the eastern part of Congo. And he was diagnosed as having Duchenne muscular dystrophy because the parents have a little bit of money. They could go to India and they were offered for 10,000 euro a test which was completely fake. and that demonstrated Duchenne muscular dystrophy. It's obviously not Duchenne muscular dystrophy. When you know the disease, you immediately recognize it's not Duchenne muscular dystrophy. Then an old child neurologist from Belgium came in Lubumbashi and looked at the patient and say, it's not Duchenne muscular dystrophy, maybe spinal muscular atrophy. You should go and see Laurent in Liège. Obviously, it's not spinal muscular atrophy neither, but if you know this disease, you recognize quite easily congenital myasthenia related to DOX7 mutations. And the beauty of this disease is that it actually responds very, very well to salbutamol, which is a drug that you can find for €7 per month. So that the same patients 2 days after the onset of treatment, and you can see the difference. Today is completely normal. He runs in the street of Lubumbashi. He was lucky because he could get the diagnosis, but how many patients are around without a diagnosis? How long do they need to wait for this disease? Is it that rare? Not that rare. This was a little some weeks ago in Egypt. I was introduced with kids, with twins, and they had 2 brothers who died before them of this disease. Look, the same hypotonia that they now our friend from Lubumbashi, a little bit of salbutamol, and that the same guy 3 weeks later in the living room. He has a brother, so you can double the pleasure. And that's the twin brother. And that's the twin brother after the onset of salbutamol. So yes, we have plenty of other diseases that we could treat very efficiently, especially if we treat early, not with drugs that cost millions. Here, it's a drug that costs €7 that you could give anywhere in the world, in Lubumbashi, in Egypt, even in the UK. So we have several patients like this in our center in Belgium. We have 3 patients like this. One was published in German Neurology, excellent journal, and one to the equivalent in Belgium of the Daily Mirror in the UK. So different impact factor. Altogether, they spent 70 years in the wheelchair. They spent 20 years with the invasive ventilation, 30 years with the non-invasive ventilation, 5 muscle biopsy, over 50 years with no productivity, a lot of house adaptations, a lot of social support, a lot of money, a lot of human lives that are spoiled just because we do not screen. So that's our vision of the future of newborn screening. We should start thinking newborn screening another way, much more dynamic. That's why I've chosen this Belgian symbol, which is the rocket that went on the moon 10 years before the Americans, bringing Tintin on the moon 10 years before Armstrong. So first, we could improve the present screening by taking conditions that we don't screen properly. And then we could screen all the diseases that have treatment today. And guess how many? 124. 124 diseases could be screened at birth and treated at birth if we were using the right methods. And then we have all these diseases that are coming under the spot. Angelman syndrome. Dora, you can confirm how many trials we are going to start with Angelman syndromes. Sooner or later, we will have to go to newborn screening for Angelman syndrome to detect this at birth and to treat it as soon as possible. Altogether, it makes 200 patients per year in the UK who could be treated efficiently, who could have a normal life if we were clever enough to screen these patients. And if we were clever enough to put this in place, we could accelerate the development in the field of rare disease. So as a matter of conclusion, again, I will invite René Magritte with a painting that is called La Clairvoyance in 1936, which is actually all my vision of the clinical development in the field of rare disease. So this is the clinical researcher. He's actually conducting a very precise clinical trials that aims to demonstrate the safety and the proof of engagement of the drug in post-symptomatic patients who are already born. And look, he is looking to newborn screening and to pre-symptomatic treatment. So if I want to reconsider my own personal experience in the field of rare disease from 2008 to 2022, and to consider 2 other very important dates. The first one is the 1890, which is the description of spinal muscular atrophy by Johann Hoffmann and Guido Wernicke, and a very super important date, which is my retirement. I look forward. And, you know, I will probably be an old man, you know, telling always the same story, the same jokes, you know, and say, oh, you know, when I was a young child neurologist, I still have seen kids dying of spinal muscular atrophy type 1. Can you imagine? And maybe the son, the daughter of Julien and Clara will say, hey, Dad, could you please give me a break with the old stories from the past? So that's my wish. That's my vision for the next years. And if we together as a community, we as a team can contribute to that, I would be more than happy. And well, thank you again, my previous team in Paris. And I was so happy to see Andrea and Christelle from Paris, my new team in Oxford, my team in Liège, and my partners in crime in Liège for newborn screening. Thank you very much for your attention.